For that great presentation. We're going to move on now to the pediatric world. So we're moving to the pediatric brain, and it's my pleasure to introduce our next speaker, Dr. Mei-Lan Ho, Associate Professor of Radiology and Director of Translational Imaging at CORE, and also Faculty Lead of Imaging Genomics Research Affinity Group. Welcome, Mei-Lan.
Thank you so much, Dr. Torres, for the invitation to this great global meeting. So these are my grants, nothing related to the content of this talk. So the objectives today, I'm going to try to put together some of what came before with regard to the pediatric world. So we are going to highlight the emerging roles of genomics and advanced imaging, particularly with the WHO 2021 updates. We will review key imaging features of pediatric brain tumors as well as mimics, because there are quite a few mimics. And doing this, we'll utilize a location-based approach for the differential diagnosis, and I think it'll be helpful for essentially just, metacognition. All right, so it's just stepping back, what is a tumor, right? So there's actually a whole spectrum, right? You can have irritation with the hyperplasia, metaplasia, dysplasia, and so you can change the number, the order, the size of cells, and these are still technically reversible. But then as you progress to anaplasia and neoplasia, it becomes irreversible, right, and autonomous. And so particularly in pediatrics, I think this concept of the dysplasia to neoplasia spectrum is very important because we have a number of underlying genetic mutations which can predispose to dysplasia formation, and then with another hit, essentially, in the genes, you can essentially progress to irreversible neoplasia. So that's a very important distinction. So what are some of the unique pediatric considerations for brain tumors? Well, certainly normal development is very complex and age-related, so we have myelination and sulcation, and then as the brain develops and we have hormonal influences, genetic influences, we have different disease processes and vulnerabilities. And then how do we distinguish tumor versus mimic? So obviously the age, the symptoms, and time course are important. Was there any antecedent infection or trauma and so forth? And also location and imaging features, so that's going to be very important. All right, and here I'm the classic differential vitamin C or whatever you like to use, but just to remember that a lot of these things are important potential mimics to consider in pediatrics, particularly some of the congenital, metabolic, and autoimmune stuff. All right, so WHO 2021 was excellently reviewed by Dr. Huang, so I just wanted to reiterate the importance of the layered report, right? So we have many different layers, the classic histology, the grade, and the molecular information. And really what we want to get toward is an integrated diagnosis to make sure that all of these agree and complement each other. The thing is we keep finding out more, right, about molecular signatures, and so it is a hybrid and evolving taxonomy, which is why we have the C-Impact Now updates in between the last iteration of WHO and the current iteration. And the idea really is this precision medicine approach that we want to have, more precise diagnosis, risk stratification, prognosis, and targeted therapies. So why image? Because you don't see imaging really in any of this layered report, right? So it's very important for us as radiologists to really emphasize this among our clinicians, that the location, where does it arise from? Was there a biopsy error? What is the extent of the tumor? And then are there distant metastases for staging? Also, it's non-invasive to image. You don't have to go in, you don't have to get the tissue for molecular testing, and you can evaluate longitudinally. So it's really you're sitting on this gold mine of information. And with that, you can perform advanced imaging. So you can find more about tumor biology, not just macrostructure, and also look at quantitative biomarkers, as was described by the radiomics speaker. All right, so just a mention about advanced MRI techniques. This has been excellently covered by several prior speakers, but I just wanted to emphasize, even in pediatrics where we have limited scan tolerance, you can't scan everyone with every sequence, but there are certain use cases where it can be very helpful. And so for diffusion, obviously we have ADC to look at tumor cellularity. So here's a classic pilocytic astrocytoma, and as you know, they can be solid and cystic, but even the solid components tend to be facilitated diffusion. And then you can also use tractography to look at white matter fiber. So obviously this one was infiltrating and very closely associated with the corticospinal tract, so important for surgical planning. Perfusions is one of the same questions, so there are actually 3 ways to do MRI perfusion, as we know. I happen to like arterial spin labeling in kids because you don't have to give gadolinium, right? And we know gadolinium deposition, especially in kids and with repeated contrast exposures, may have potential negative effects. So with arterial spin labeling, you're looking at capillary microcirculation. You're using endogenous water as the tracer. And so you label, the protons at the base of the brain, you measure them, and it gives you an absolute cerebral blood flow. Now, there certainly are other ways to measure perfusion in tumors, and obviously this is the standard which most of us do in clinical practice with the first pass gadolinium negative contrast dip. But you can also do dynamic contrast enhanced imaging. It just takes longer because you now have to measure the delay, but you can actually measure the partitioning between intravascular and interstitial spaces, and so that gives you information about tumor permeability in biology. So just some examples. So again, there's a lot of correlation between these different techniques. They do measure slightly different things, but capillary microcirculation, you can look to really target the highest grade of tumor for a biopsy or surgical resection or distinguishing from treatment effects. And certainly you can also look at more permeability parameters as well. Functional MRI is primarily for pre-surgical mapping of eloquent cortex. So this is based on the BOLD response, looking at blood oxygen, right? So if you perform a task, there'll be an initial dip in the oxyhemoglobin, followed by compensatory autoregulation, and that's what we measure with task fMRI. So the idea is that you can test for motor, language, visual, whatever eloquent functions. And the idea is that if all of the eloquent areas are at least 1 gyrus width away from the tumor of interest, then you can do a safe resection. Otherwise, you may need to go and do intraoperative cortical stimulation with awake craniotomy. Spectroscopy, looking at metabolite concentrations. There's a number that you can see, and essentially, as described by Dr. Torres, you can distinguish recurrent tumor, necrosis. You can certainly do a single voxel imaging to interrogate an area of interest with high signal-to-noise ratio. You can also do multi-voxel imaging to look across the field. It just takes longer and has a little lower signal-to-noise, but it can really help in terms of mapping really the range of the tumor across multiple voxels. All right, so now we get to our location-based approach on pediatric brain tumors. So I'm essentially going to show different tumors and mimics in each location of the brain. So Dr. Huang referred to the diffuse glioma classification. So ironically, in the 2021 classification, the adult gliomas got simpler, but the pediatric gliomas got much more complex. So we used to call everything, diffuse gliomas, and now we have several molecular classifications, 4 low grade, 4 high grade. The high grade ones have this histone H3 different mutations, and so that helps package chromatin DNA. And so when you have these mutations, it makes it more unstable and more likely to be mutated. So this is a nice little schematic in terms of a lot of the different molecular advances. You can see the low-grade tumors and the high-grade tumors, and we'll talk a little bit more about that later. You also have your classic astrocytic gliomas, so the pilocytics, the pleomorphic astrocytomas, and so forth, and your glioneuronal tumors. So I'd like to bring up this concept of the long-term epilepsy-related tumors. So there are many dysplasias/low-grade tumors in pediatrics which can do very well. They may have seizures if those tumors involve the cortex, but otherwise very stable over multiple years, and with resection have very good outcomes. So this is a fairly recently described entity, the multinodular and vacuolating neuronal tumor. People used to think they were DNETs at pathology, but they're pure neuronal lesions. They don't have any glia in them. And so characteristically, you see a bunch of separate little nodules in the deep cortex and or subcortical white matter. And some people think this is actually dysplasia, not a true tumor. So again, that whole dysplasia-neoplasia spectrum. Okay, this is a real DNET, right? So this bubbly appearance, and you see that it actually suppresses on flare except for the rim. So again, it really is almost like a hamartomatous, right? It's the same kind of tissue as the rest of the brain, but just disorganized. So again, some people think this is really on the border between dysplasia and neoplasia, but clearly low grade if it is neoplastic. And then here's another JPA. This one is just, solid. You can have solid, cystic, anything in between. And they can have waxing, waning enhancement. It doesn't really change the prognosis. It just has to do with their microvascular proliferation, but that's the natural history for pilocytics. So there is, this is probably overkill, but someone used the DNet and decided that all of these leads could be classified from A to I or whatnot based on their original pathology and the fact that they were long-term epilepsy-related tumors. So I don't think you need to actually know this, but it's just interesting to see that many different low-grade pathologies can be associated with chronic epilepsy in kids and actually do very well and are very stable over time. So what are other things that can cause seizures? So I think it's very important to note that in kids, temporal lobe epilepsy, either underlying dysplasias or post-ictal, they can look swollen and they can actually look like pseudomasses in the acute stage, right? So here we have an edematous hippocampus and it's hyperperfused on ASL, right? It's not until multiple seizures have gone by, you have that neurotoxic effect, that you get the classic MTS in older kids and adults, right? So now you have this shrunken, bright hippocampus and diffuse hypoperfusion. Other things associated with seizures, so obviously limbic encephalitides, either infectious or autoimmune. You know, this one you would be looking for underlying teratoma, paraneoplastic. So they often will have that bilateral involvement. It tends to be more asymmetric with HSV, and they can have more enhancement, hemorrhage, and so forth. Whereas the autoimmune conditions often have somewhat more symmetric appearance and relatively less enhancement. If they do have enhancement, it tends to be thin and very smooth. Okay, so NF1, this is the most common phakomatosis, right? And so I wanted to mention NF1 because it really highlights that whole dysplasia neoplasia spectrum. So neurofibromin is a tumor suppressor that involves the RAS-MAPK pathway, which is involved in cell signaling and all sorts of critical functions. And so when you have loss of that tumor suppression, you get a bunch of dysplastic type things. You can have megalencephaly, megacorpus callosum. The hippocampi are always dysplastic looking because there's a lot of neurofibromin in them. You can have optic pathway gliomas, which anecdotally can sometimes regress. So not like the sporadic ones, but very expanded. You can have plexiform neurofibromas, sphenoid wing dysplasia. So we've all seen these cases. The thing is that it's not always just dysplasia, right? You can get tumors as well. So these classic focal areas of signal intensity, these little like white matter, they're actually areas of dysmyelination, right? Because the oligodendrocytes and the Schwann cells also need neurofibromin, and so they produce disorganized myelin. But over time, this repairs, and so these can bloom in the first decade, but they gradually resolve, and then you're just left with maybe a little bit of gliosis. However, it is a tumor suppressor, right? So if you get a second hit, right, you get a somatic mutation, for some reason you further deregulate this pathway of tumor suppression, these things can convert to gliomas, and not just low-grade ones. I've seen GBMs which looked fairly innocuous, but all that you're getting is just, some growth after when they were supposed to resolve, some infiltrative appearance, some new enhancements. So this is why these patients get yearly follow-up just to look for any suspicious conversion of these focal areas of signal intensity. So going along this concept of somatic mutations and overgrowth, right? So a germline mutation is one you get from your parents, and it's every single cell. But as your fertilized zygote, divides, right? You can get what's called a somatic or a post-zygotic mutation, right? So you go to like 8 balls or 16 cells, 64 cell, right? So imagine that one of these cells acquires a mutation. So every daughter cell from then on will have that mutation. So part of your body will have that. So depending on the timing, right, you can get just a focal area of dysplasia, you could get a lobe, a quadrant, a hemisphere, or even the whole body, right? So it's all about timing. So all of these overgrowth syndromes, vascular anomalies and hemihypertrophy and hemimegalencephaly, all of these things have been linked to the mTOR pathway, which is another, cell cycle regulation. So these focal cortical dysplasias, if you're lucky, you can see a radial glial line because this is basically how the neuroglial progenitors migrate out, right? They go from the ventricles all the way to the cortex in the radial pattern. But a lot of times you're not that lucky, and so you may get a deep sulcus, enlarged overlying subarachnoid space, some blurring, right? I sometimes will see reports saying, low-grade glioma versus cortical dysplasia. You usually can tell them apart, right? If you see the radial line, that's very diagnostic. The fact that it's at the bottom of the sulcus, right, because of that migrational line, looking for that enlarged subarachnoid space, so they're volume neutral or even volume loss, right? Whereas a glioma is going to be puffy, and then a glioma, if it grows, it could be eccentric to the bottom of the sulcus, and it could grow along the cortex. If it does infiltrate, it's going to go down white matter, not radially. So megalencephaly, it's not just hemimegalencephaly, right? You can have various patterns depending on the timing of the mutation. And then tuberous sclerosis, right? That's an mTOR pathway abnormality, but essentially it's just multifocal cortical dysplasias. You can have a bunch of radial lines. These tubers are essentially just dysplasias. And you know, if the neurons can be dysplastic, why not the vessels too, right? So having enhancement, having cystic change or calcification doesn't mean anything. That's expected for dysplasia. The sagas and the hamartomas, these are also just essentially trapped, you know, neuroglial progenitors at the level of the ventricles. And then with another hit, they can become sagas, which is why you can use mTOR inhibitor drugs to both reduce the size of sagas and have seizure control for the tubers. So now we're going to white matter. So the first thing you want to know is this just gray matter in the wrong place? So when gray matter follows a signal of everything else around it, I notice that the cortex is kind of abnormal and there's a swirling pattern. So these are really pseudotumors. Large perivascular spaces in the anterior superior temporal gyrus of the basal ganglia, if they're very large, they can kind of cause some local ischemia and have a little bit of flare signal, but they're still perivascular spaces, they don't enhance. Toxic leukoencephalopathy, so particularly methotrexate, high dose intrathecally can give you restricted diffusion, classically in the centrum somio-valley, sometimes in the splenium, but that's a very classic look as well. And then radiation necrosis has been excellently described, this kind of feathery migrating enhancement. It often has matched mineralization and then perfusion-diffusion changes, so it evolves very quickly. Demyelinating disorders, this is the third same question. So so when you're looking for demyelination, I think it's very important to know the clinical history, the phasicity, the CSF serology, and then do brain, optic nerve, and cord imaging. So neuromyelitis optica with the, kind of cloudy periventricular enhancement, ADEM with the fluffy, multifocal enhancement, and then MS with the perivenular enhancement. So these have slightly different imaging characteristics, but they can overlap, and that's why the serology and the history become important. They can all present with the optic neuritis, and the myelin oligodendrocyte antibody, the MOG positive cases, these can all be MOG positive, but they can have this kind of shaggy enhancement in the optic nerves. It can be confused in the acute phase with gliomas, but much more inflammatory looking and resolves with steroids. So the basal ganglia, I mentioned that the high-grade gliomas, the histone proteins, are kind of poor prognosis, right? So we have the diffuse midline glioma linked to this H3K27M alterations. And so these can be in kind of paramedian, right? So in the thalami, the brainstem, the cerebellum, and the cord. These don't do very well, unfortunately. There's also another mutation which has been recently described, H3G34, and these can involve vasoglia, but tend to be much more infiltrative and lateralized, so hemispheric. Other things that involve the basal ganglia, so post-flu or metabolic, deep venous thrombosis or artery of Percheron, vigabatrin, which is a GABA analog, so it's basically inhibitory neurotransmitter, so you can get this restricted diffusion look when you're treating infantile spasms, and then Wernicke, which is kind of uncommon in kids, especially in the modern era, to have thiamine deficiency, but you can't have that mammillothalamic tracts perioaqueductal gray in severe malnutrition, like TPN or gastric bypass. So you'll notice that all of these are kind of like metabolic toxic things, but the history is very important. They're symmetric, they're not infiltrative, they're not enhancing, right? And then if you basically treat the underlying issue, they will resolve. Hypothalamic lesions, so gliomas, astrocytomas, they can be solid cystic. They're classically very infiltrative, optic and optic pathway, hypothalamic. The germ cell tumors can be solid cystic, but they can also have areas of bulk fat, calcification. You can see them kind of crawling along the leptomeninges as well, so that's a classic look. Hypothalamic hamartomas are actually just heterotopic gray matter, so they can be pedunculated or sessile, but they don't have any enhancement. They're just gray matter in the wrong place. There are some things that are actually not hamartomas. So if you just see a midline adhesion or band of gray matter, that's not a real mass, it's an adhesion. This has been recently linked to X-linked deafness, so the corkscrew cochlea, a Stapes gusher, and also heterotopia. There's another syndrome, median cleft face or frontonasal dysplasia, where essentially the median palatal shelves are too far apart. You have hypertelorism, so you can have cleft palate. And in this disease, this disorder, right, there's a tuberomammillary fusion body. So instead of the third ventricle coming to a point, there's actually this fusion body that runs along the bottom. And that's just the normal appearance of this disorder, right? You can have duplicated pituitary, duplicated odontoid processes, et cetera. So it's not an actual hamartoma, it's just what this disorder looks like. Pituitary gland, we've all seen the adenomas, right? So hypoenhancing relative to the normal gland. They can invade the cavernous sinus. They can go up into the suprasellar or down at the clivus. Langerhans cell histiocytosis is proliferation of dendritic cells, and so this, you can lose the posterior pituitary bright spot. The infundibulum is a common area for these, but also bone lesions you can see quite frequently. And then the craniopharyngioma, so now in WHO 2021, the adenomatomatous pediatric version is separate from the adult, papillary histology, but this one will be Rathke cleft remnant, so you get this kind of crankcase oil, very solid, cystic, sticky appearance, very adherent. In the pineal region, so pineal parenchymal tumors, the pineoblastoma is grade 4, right, and so it's very ugly, large, cystic, hemorrhagic. Pineocytoma is much more well-defined and hypoenhancing. Germ cell tumors, again, can have the bulk fat, the cystic stuff, and then they can spread along the leptomeninges, so that's very characteristic. And then pineal cysts can be either small and multiple or large, and if they're very large, they can actually compress the tectum and the aqueduct. Okay, so posterior fossa, medulloblastoma, we know that there are many subtypes, right? So it's all molecular, so the wingless subtype comes from the rhombic lip, and so that gives rise to these ones that kind of insinuate and involve the brainstem and the CP angle. The sonic hedgehog comes from the granule cells, which guide migration, so those go out to the lateral cerebellar hemisphere. They have this desmoplastic nodular appearance. Unless they have this additional mutation, then they become more necrotic. And then there's the group 3 and 4, so these come from, stem cells, so they can present with metastases, or these guys actually come from the deep cerebellar nuclei, so they're more in the midline. And there are actually a number of familial germline cancer syndromes associated with medulloblastoma, so it's important to evaluate and test for these. So just some examples. So here you can see the sonic hedgehog in the lateral cerebellar hemisphere, very restricted diffusion, very nodular. The TP53 mutation ones have more kind of necrotic appearance and less restricted diffusion. The wingless involves the brainstem and the cerebellum, and then the group 3 is more in the midline and mildly enhancing. If you see a medulloblastoma type looking thing, but in a young child like less than 2, you want to think of ATRT. These are associated again with these chromatin remodeling type mutations, but you can see rhabdoid tumors in the posterior fossa, the sinuses, the cord, and so forth. Ependymomas are from ependymal cells, so they're these soft toothpaste-like lesions kind of in and around the ventricles. They can have calcification, cyst, and hemorrhage. Very diverse molecularly, but in the posterior fossa they have group A and B. The group A is younger, poor prognosis, unstable methylation, and these tend to be more lateral. The group B is like older, more midline in the obex, almost like the subependymomas. And differential diagnosis, so viral or infectious rhomboencephalitis, you have this symmetric appearance, very thin or minimal enhancement. You can have brainstem findings. Osmotic demyelination, with correction of hyponatremia. Again, it's kind of this, central pons, but again, pretty symmetric, and history is very important. Finally, CSF, right? So choroid plexus tumors, enhancing, feathery, and hypersecreting with CSF. You can have lipomas or xanthogranulomas degeneration as well, and then colloid cysts, which are congenital things. This is an important, recently described tumor, diffuse leptomeningeal glioneuronal tumor. So these are like all over the subarachnoid space, and very few parenchymal lesions, if any, usually in the cord. So there's actually 2 different molecular subtypes have been described now. So this is kind of oligodendroglio-like and younger. The older ones that are more aggressive, you can see this one's going all around the optic nerves and much more nodular and coating the cord. Other things you can see, obviously, nodular metastases, carcinomatosis, basilar meningitis with TB or fungal or granulomatous disease, and then complicated sinusitis, which is common in kids to have these subperiosteal spread through these valvulus veins and get empyemas. And finally, cranial nerves are also CSF, so you can have lesions like schwannomas or other cranial nerve lesions. You can have actually this ophthalmoplegic neuropathy, which used to be called ophthalmoplegic migraine. So it's actually an inflammatory syndrome with headache and transient, eye ocular motion problems, but it resolves with steroids. Lyme disease can give you multifocal enhancement, any kind of atypical infections, but also demyelinating disorders like genetic disorders with demyelination and remyelination can give you enhancement as well. So in conclusion, a fully integrated diagnosis for brain tumors involves histologic imaging and molecular features. Informed utilization of advanced MRI techniques helps improve diagnosis and management, and a location-based approach helps us to classify pediatric brain tumors and mimics. Thank you so much.